Hello, everyone, and welcome to Echo Asthma Bootcamp. My name is Ashley. I'm your facilitator. I'm joined today by my coordinators, Rachel and Tabitha, as well as our wonderful hub team, Dr. Mandeep, Jassal, and Dr. Christian Hermansen. Today, we're going to talk about biologic treatment options in severe asthma. Okay, so we're just going to jump right into our lecture hosted by Dr. Care.
So welcome everybody to today's Echo Asthma program, session 4 on biologic treatment options for severe asthma. My name is Dr. Sucharita Kher. I'm an assistant professor at Tufts University School of Medicine and an adult pulmonologist at Tufts Medical Center. And I look forward to spending the next hour with you talking about some of the exciting biologic treatment options we've had in severe asthma. So starting with the GINA guidelines, we've reviewed these before. GINA guidelines do not necessarily specify which exact drug to use, but really provide us with guideline to help selection of a treatment for a particular individual patient. And that really depends on the patient's own disease characteristics, their preferences, what phenotype of asthma they may have, what their functional ability is to perhaps use a medication, and then to overall consider the complexity of the medical regimen. The biologics in asthma are among the step 5, the rightmost on the GINA guideline. So there are 5 approved biologics currently in the United States. Umalizimab, which is an anti-IgE monoclonal antibody, is the oldest. We've had about 18 years of experience with this drug. Mepolizumab was then approved many years later and is an anti-IL-5 monoclonal antibody. Reslizumab, which is an IV formulation, again an anti-IL-5 treatment option. Benyalizimab is an anti-IL-5 but really works against the receptor rather than the IL-5 molecule itself. And then the most recent kid on the block is Depilomab, which works against the anti-alpha subunit of interleukin-4 receptor. The most important thing about these drugs is that while they do significantly improve exacerbations or decrease exacerbations, improve lung function, and reduce the amount of oral corticosteroids that a patient is exposed to, it's really important to remember that these are add-on treatments. That means that it is only used for patients who have uncontrolled asthma despite the regular use of a combination of medium to high dose inhaled glucocorticoid and a long-acting bronchodilator, and people who have impaired lung function. So it's really for those patients who cannot be maintained despite step 4 GINA guidelines. A little bit more about these approved biologics. All except for Reslizumab are subcutaneous by route. Reslizumab is the only one that's IV. Some of these, Umalizimab and Mepolizumab particularly, are also approved for ages over 6. So for a pediatric population, this table highlights what the patient selection is, and we'll talk a little bit more about each of these drugs in detail and what the evidence is behind using these drugs. And then I really want to use this table to highlight some of the adverse effects. So for Umalizimab, which is an anti-IgE treatment, anaphylaxis is about 0.2% of patients. While the risk is really low, it is recommended that the patient carry and know how to use an epinephrine injection with them at all times. The risk of this anaphylaxis is highest initially when they initially get the drug, but certainly has been reported up to 7 days out. Patients also complain sometimes of local reaction at the injection site. For Mepolizumab, in some of the studies, patients have had zoster. It's rare, again, less than 1%. And the guidelines typically say to consider a vaccine against zoster if medically appropriate. It's important to note that some of these vaccines are live, and so if the patient is at risk for disseminated zoster, for example, if they're on high-dose steroids or on immunosuppression, it may not necessarily be feasible to give them a shingles vaccine. Headaches are quite common, but can be dealt with some Tylenol, and local reaction can be a possibility as well. For Reslizumab, interestingly, one of the side effects is oropharyngeal pain. Anaphylaxis has also been described. Again, it's 0.3%, so it's a low risk. However, is a real risk and is associated with a boxed warning for the drug. For Benyalizimab, this is indicated predominantly, again, for eosinophilic asthma, and some of the side effects include headache, pharyngitis, and a hypersensitivity reaction. And for Depilomab, finally, injection site reactions are common in about 15%. Hypersensitivity can be noted, and this can present as urticaria, other rashes, evidence of serum sickness. Paradoxically, these patients can also have eosinophilia, and it has been attributed in about 4% of patients who received Depilomab, as well as the presence of some vasculitis. Ocular symptoms should be looked for when patient is on Depilomab, as these patients can often develop conjunctivitis or keratitis. And I'd like to highlight that for all of these drugs, because it's meant to be an anti-eosinophilic inflammatory drug, it's really important to take a detailed helminth infection exposure history, particularly about travel or if they've ever had a helminth infection in the past. And it's important to treat that helminth infection before starting any of these drugs. So let's go through each of these drugs individually. So Umalizimab was approved back in 2003. So as you know, we have many years of data and really good data to support this drug. It has been used for patients who have moderate to severe asthma with a positive skin allergy test, and those who've been poorly controlled otherwise on an inhaled corticosteroid. The dosing for the drug really depends on what the patient's weight is, as well as what the IgE level is and the age. Typically, though, depending on these levels, a dose comes to somewhere between every 2 to 4 weeks. It's a subcutaneous injection. And the data really supports the use of the drug. Cochrane analysis a few years ago of 25 studies showed that it significantly reduced the exacerbation. And overall, there was an absolute reduction in exacerbation compared to placebo, where it was 26%, down to Umalizimab, where it was 16% exacerbations. It also has shown to reduce the risk of hospitalization, the significant absolute reduction in the risk, as well as a decrease in the risk in the utilization of inhaled corticosteroids, but not necessarily oral corticosteroids. Overall, in this Cochrane analysis, it was shown that Umalizimab was associated with less adverse reaction compared to placebo, except for the local injection site reactions, which were higher, about 9% in Umalizimab compared to 5% in placebo. Again, there is a risk of anaphylaxis. People have to carry the epinephrine injection with them, and it's up to us as healthcare providers and nurses to educate the patient about the use of it and the need to carry it with them, particularly around the time that they're getting the injection. The next is Mepolizumab. This was approved by the FDA in 2015 as an add-on therapy for severe asthma in kids 6 and over with an eosinophilic phenotype. Of note, an auto-injector is available for this drug. However, it's approved for ages 12 and above. It's a standard dose of 100 milligrams administered subcutaneously every 4 weeks. And there are really 3 pivotal studies that led to the approval by the FDA. First is the DREAM study that enrolled over 600 patients with severe asthma and tested 3 different doses, 75, 250, and 750 milligrams. And the study really showed that Mepolizumab cut down exacerbations by 50% at all doses with an excellent safety profile. The MENSA study following the DREAM study recruited 576 severe asthma patients, gave them both IV as well as a subcutaneous dose and compared that to placebo. And both IV and subcutaneous cut down the exacerbations by 50%. Not only this, it also showed improved lung function as measured by FEV1 and improved ACQ scores or symptoms of asthma. And then finally, a study of 135 patients published in the New England Journal of Medicine that recruited patients with severe asthma showed that Mepolizumab cut down oral corticosteroid dose by 50%, 32% decrease in exacerbations, as well as a better ACQ score. The next is Reslizumab. This is an anti-IL-5 drug approved by the FDA in 2016. It's an add-on therapy for patients with severe asthma, mainly for adults 18 and over with an eosinophil phenotype. Because it's an IV drug, it takes a little bit longer to administer, and it's given by an infusion every 4 weeks with a dose of 3 milligrams per kg over 20 to 50 minutes. There is a 0.3% risk of anaphylaxis with this drug. And there are 3, again, pivotal studies that I'd like to highlight here. The first one is 2 randomized controlled trials that recruited about 953 patients with severe asthma or with eosinophils over 400. This study showed that Reslizumab cut down exacerbations by over 50%, and they had similar worsening of asthma symptoms in both reslizumab in the placebo group. A randomized controlled trial that recruited 325 severe asthma patients compared two different doses. And this study showed that the lung function as measured by FEV1 as well as symptom questionnaires as measured by ACQ and the AQLQ did better in the drug or the reslizumab group compared to the placebo group. And that the higher dose, the 3 milligram per kilogram dose, did better than the lower dose. And finally, a third randomized controlled trial in chest back in 2016 recruited about 490 patients with a 4:1 randomized design, used the dose 3 milligrams per kg. And it's interesting to note that the positive effects, the benefits of reslizumab in this population was seen only for people who had an eosinophil count over 400. And hence, that's when we consider using this drug, is when people have eosinophil counts over 400. Particularly important to note that in this study, that folks who had EOs below 400 did not benefit as much. The fourth drug is Benyalizimab. This is an anti-IL-5 receptor antagonist approved more recently in 2017 for ages 12 and above with severe asthma with eosinophilic phenotype. The dose, again, is a standard dose, 30 milligrams subcutaneously. The important thing here to note is that for the first 3 doses, it's administered every 4 weeks, and then thereafter, there's flexibility to administer it every 8 weeks. There is also an option for self-injection here with a pre-filled auto-injector that was more recently approved in 2019. And again, the pivotal studies that showed, the first one was a randomized trial that showed that Benyalizimab cut down annual exacerbations rates significantly in these patients. This study looked at every 4-week administration as well as every 8-week administration, and both did better compared to the placebo. In addition, lung function was better as measured by FEV1 as well as the symptom score. Long-term data from the above study and aggregate data of over 1,100 patients showed that 75% of these patients had a decrease in more than 50% dose of oral corticosteroids after about 84 weeks of treatment, and 39% of patients identified a more than 90% decrease in the steroid use. So it really helps cutting down steroid use and exacerbations in these patients, in addition to improving lung function and symptoms. And the most recent drug is Depilomab. It was approved in 2018 for ages 12 and above for patients with severe asthma. It's an anti-IL-4 receptor alpha monoclonal antibody that further blocks the downward signaling both of interleukin-4 and interleukin-13. It's approved for 2 different doses. We also have some long-term data for this because it has previously been approved for another indication for atopic dermatitis, and more recently for asthma. Both doses are self-administered, they're subcutaneous administered. The first dose is 400 milligrams for the first dose, followed by 200 milligrams every 2 weeks. And then if the patient has oral corticosteroid dependent asthma, then it's recommended that a higher dose be used. This is 600 milligrams for the first dose and then 300 milligrams every 2 weeks thereafter. Home administration is possible. And there are pivotal studies that show that it cuts down exacerbations by 47% in patients who were treated every 2 weeks, associated with improved lung function. And another study of 200 patients showed that it cut down the dose of oral corticosteroids by 70% in the drug group or the Depilomab group compared to only about 42% in the placebo group. And 80% of Depilomab patients had at least a 50% steroid dose reduction and a 59% lower exacerbation in the Depilomab group. So really tremendous amount of data with all of these drugs. Now, while there are 5 approved drugs by the FDA for patients with severe asthma, I'd like to mention at least one, Teslapilimab, which is currently in development. And these are the results of the phase 2 trial that came out a couple of years ago in the New England Journal of Medicine. Teslapilimab is an antibody that is directed against the thymic stromal lymphopoietin, or TSLP, which, if you remember, is pretty upstream on that graph that we discussed last time in the inflammatory pathway. And this study is called the Pathways trial. It's a phase 2 randomized double-blind placebo-controlled trial of Teslapilimab in patients with a poorly controlled moderate to severe asthma despite medium to high doses of inhaled steroids. And they recruited over 580 patients that were randomized to either placebo, which are the gray bars, or the colored bars, which are different doses of Teslapilimab. And what you could see is that there was significant reduction in the annualized rate of asthma exacerbation in the 3 doses compared to placebo. Most of these p-values are just statistically significant with the exception of a couple. I think the most important take home from this, although it's a phase 2 study, the importance here is that the drug decreased severe asthma exacerbations independent of their type 2 status. So one thing to highlight is all the 5 drugs that we have so far that are FDA approved have been approved for type 2 asthma. We do not have any FDA approved drug for non-type 2 asthma. So this is really exciting that this drug has potential for helping our patients who have non-type 2 asthma, who really don't have much with the exception of our standard inhalers at this current time. And it's one of the reasons that the drug was fast-tracked by the FDA in 2019, and more to come about this in the future. I'd like to also briefly mention the role of bronchial thermoplasty. This is rarely done, but I think it's important for us to talk about it. It involves 3 bronchoscopic sessions that leads to radiofrequency ablation or heat wave application to the airway smooth muscle. As you know, the smooth muscle in asthma plays a very important role in bronchoconstriction. And so this applies radiofrequency ablation to the smooth muscle in the airway. The effects have been studied in the short term, unfortunately, because of the bronchoscopy and the airway irritation, it actually leads to increase in asthma exacerbations. There was also a large placebo effect noted in these clinical studies. Long term, however, it has been shown to reduce exacerbations as well as improve symptoms in the following year. There's no clear evidence, however, to guide patient selection as to who's going to benefit, who's not going to benefit. And so the current utilization is really restricted to clinical trials or registry uses. So I'd be really amiss if I didn't talk about COVID-19 and what to do with these biologics in our current pandemic climate. There is a paper that was recently published where a group of experts across the world really got together to discuss what to do with patients who are already on biologics in the pandemic or if they get COVID-19 infection. And so these are some of the highlights from that paper. Again, I have to preface this by saying there's not a lot of data to support it, but these seems to be reasonable conclusions. First, in the absence of data that would indicate any potential harm, continuing the administration of biologics during a pandemic in patients in whom such treatment is clearly indicated and has been effective. Second, in prior studies, no risk of increased infection susceptibility or immune suppression effect has been reported to date. In fact, Umalizimab had a possible anti-infectious effect, and hence they recommend no need to discontinue the drugs during a pandemic. And until more information is available, patients with severe asthma plus comorbidities infected with the SARS-CoV-2, decision for maintaining or postponing biologics until patient recovers should really be done on a case-by-case basis, supported by a multidisciplinary team. Our experience here in my institution is that we've continued people on biologics and they've done well. Some patients, we've actually transitioned them to home administration to avoid having them come in to the institution for shots, particularly for the need of physical and social distancing and avoiding exposures. Particularly for Umalizimab, there has been some provision that has been provided for the pandemic to allow a self-administration at home with certain guidelines in place that we can discuss at a later session. So I'd like to finish up by talking about some of the guidelines for referral to an asthma specialist. These, in my mind, include patients who've had a life-threatening asthma exacerbation, such as those who've been in the intensive care unit, potentially intubated for their asthma, patients who, despite appropriate treatment, have not met their goals, patients with atypical presentations who we question the diagnosis of asthma, patients with particular comorbidities such as ABPA or allergic bronchopulmonary aspergillosis or eosinophilic granulomatosis with polyangiitis, patients who you are potentially considering biologic treatment, patients who require consistently step 4 or higher treatment according to the GINA guidelines, patients who require 2 or more corticosteroids in 1 year, as well as folks who require hospitalizations for exacerbations. Thank you for listening and for your attention, and we'll open this up for Q&A.
All right. Thanks, everyone. Thank you, Dr. Kerr. So, Mandeep, what are our key takeaways from this lecture?
It was a terrific lecture. I know there was a lot of material, but I'm going to try to focus it on the pediatric elements as much as possible. So the first thing is I want to talk about the 5 FDA-approved biologics and the ones that are pertinent for us in pediatrics. So the first is those approved for those 6 years and up. So Umalizimab or Xolair, or Mepolizumab or Nukala. So those two are approved for those 6 years and up. And Xolair is the oldest one on the blocks, and it has a pretty favorable side effect profile. So it's generally a pretty decent biologic to apply. There's a couple things of note depending on your weight or the total IgE when you start off the dosing, because it depends on dosing and weight as well as age. It can vary between being given every 2 weeks or every 4 weeks. Right now, we recommend to be given in the office setting, largely because of the risk of anaphylaxis that can happen months on therapy, although super rare. Because of those concerns, it's recommended in the office setting. The other is Nukala, which comes in 2 formulations. Now, the home pen or the home auto-injector option is at a higher dose. So that can work for the adults or the older populations. But for kids, because of the formulation, we'll often give it in the office setting if we are going to give it. And it's newer than Xolair in the sense of approval, but it's still an older drug. So we still have it still has a lot of benefits. Now, those who are greater than 12 years of age, we have 2 options that we can add on to those existing 2s, and that being Benyalizimab or Fasenra, and the second being Depilomab or Dupexent. Now, Fasenra is an interesting one, mainly because it reduces the number of injections you need. So you'll need it every month for a period of 3 months consecutive, and then you can space it out to every 8 weeks. And as you can imagine, it is very traumatic giving injections to kids sometimes, especially in these early phases when they're just not used to getting these. And to give them an option of spacing it out, they would probably find it, the caregivers particularly would find that preferable. So Fasenra being an interesting one. And then Dupexent, initially approved as a severe eczema drug, it's now approved as an asthma agent. So that's a nice option for those with bad eczema and asthma. So you can treat 2 things decently at one time. So not too unusual to see both together, obviously, because of the atopic findings. That being given about every other week. So it's a little bit more frequent in terms of dosing. And then she mentioned Reslizumab or Singh. That one is recommended for only those who are greater than 18 years of age, and that's an IV formulation. So not rushing to give that to kids, and let alone putting in an IV into someone, especially someone so young, is not something that we are going to be using anytime soon in the world of pediatrics at this point. So in terms of the reason for biologics, right now, it is those who have eosinophilic asthma. So not non-eosinophilic asthma, but eosinophilic asthma. So what are we looking for? As we mentioned in past weeks, we want to know what that CBC looks like. We want to look at those absolute eosinophil counts to drive our thinking to say, is this eosinophilic asthma and can we do more? And what I mean by more is it's an add-on therapy for biologics. We don't use it in isolation, we add on therapy. And then the other component is you could get exhaled nitric oxide. I don't use exhaled nitric oxide at my institution, but if you do, that could be another potential way to differentiate eosinophilic asthma based on age. It can be having a higher level. So in other words, for kids, greater than 35 parts per billion or greater than 50 for adults, can give you an idea that it's more eosinophilic or total IgE levels. Dr. Kerr mentioned that Xolair is approved for those with a total IgE of 30 international units per deciliter. So, things like that can be very helpful. In terms of the adverse reactions, most in general tend to be, in terms of the profile for the ones in kids, we in pediatrics tend to be conservative. We get the ones that have been used in adults for a while, and then we get it in kids. But in general, Nukala, Xolair has a pretty decent side effect profile. Nukala, you do worry about herpes simplex virus, like she mentioned. It is rare, but something that needs to be thought of. And then then the other thing too that I wanted to emphasize here is probably a common question being asked are all biologics equivalent? We keep talking about these biologics. Which one is better than the other? Should I start Nukala? Should I go with Xolair? I don't know. And the truth is, I don't know either. We don't have any really good head-to-head trials of these drugs. So, and this is a frustrating thing for most pulmonologists and allergists, is because the nature of how these drugs are studied and how they are approved and how, there's a marketing component as well, it gets a little bit difficult to figure out which one is better than the other. So something to consider as you think about it. And then you might ask, when do you stop it if you start it? And that gets a little bit tricky. I do it for a minimum of 6 months, and then we can continue it on for a year plus to see when we get good control. And after we feel like we got into a sufficient level of asthma control, we may consider stopping it. And then seeing how control is after that point on just a inhaler and or an oral regimen as well too. Going forward with some of the other thoughts, I'm sorry, it's a very loaded lecture, and I just want to make sure we hit all the pediatric points. For kids, the NIH now, as of December, is recommending anyone with severe asthma between the ages of 6 to 11. With severe asthma, we should consider starting them on Xolair. So for severe asthmatics between the ages of 6 to 11, consider Xolair. The NIH is saying that if you're greater than 12 and you have severe asthma, you should consider all the other biologics along with those options. So in other words, put biologics on your priority list for starting newer forms of therapies to get them under good control. Gina, the one that Dr. Kerr had mentioned, copies that as well too, but recommends that as its final stage. So kind of similar in that respect. Dr. Kerr mentioned about Teslapilimab, but that newer drug is just in phase 3 trials. It is not yet out there for FDA approval. So I just want to emphasize that it's going to be really great in the sense where, you can have a potential drug to treat non-eosinophilic asthma, something we all have to deal with. And so a very helpful form of therapy. And then bronchial thermoplasty, she briefly mentioned, it's only indicated for those who are greater than 18 years of age. The NIH conditionally recommends not using it. Usually you don't see the immediate benefit in the first couple of weeks. It usually takes many months to see a great benefit from the therapy. COVID and biologics, we haven't stopped. We continue with the biologic regimens despite the COVID. Unfortunately, we don't have, for some of our families, especially our families that don't feel comfortable giving injections to kids, the idea that you can easily convert to a home setting, although that's preferable in select populations. But those, for example, in my families in Baltimore, it's a little bit harder for them to feel comfortable. And so we continue to bring them back on a monthly basis or an every 2-week basis. And we try to, emphasize the safety component as well too. And then, as I mentioned, or I think she finalized her talk on when to refer. Anyone with moderate persistent asthma should be referred to a specialist. So if you're on a moderate dosage of drug, you can base that on GINA guidelines. Those needing 2 or more steroid courses a year or 1 hospitalization or greater, they should be seen by a specialist at that point. And I just want to finalize one component, and there is the thought that these are being underutilized, and I think that's a really important part because we do know from recent studies that this is predominantly prescribed biologics to those who are middle-aged, those on commercial insurance, those with higher incomes, and those who have access to a specialist. So that's based on recent data that came out of Optum's lab's warehouse. So that retrospective data is a very interesting one, but it does tell you that we're focused on very select populations when we need to consider it in a broader range. So with that being said, that's the key takeaways from the talk.
Yeah, I don't know if can you hear me okay?
We can.
Okay, so from a family practice perspective, I think that last point is kind of what I was thinking of, because there was really no discussion of cost of some of these medicines, and it does take a fair bit of paperwork and prior auths for my mostly Medicaid population to try and get them done for people. And it's not just the medication. If you're also worried about hypertensivity, now you're prescribing an EpiPen or an AubiQ, and they are not cheap either. In fact, my son unfortunately just put some in his snow pants and put it through the wash. So we're going to have a discussion after this call today. But, you know, if we look at some of the slides and the studies there, you have something that can significantly decrease exacerbations, to significantly decrease steroid use. And if I had any other drug that I would, you know, hear about, I would be more likely to give it knowing that. But I think a lot of us in our training, we're not used to using medicines we can't pronounce. We're not used to using monoclonal antibodies. Now, perhaps now that we're in times of COVID and we're managing or monitoring for hypersensitivity when we give out the vaccine, or as we get more comfortable with things like Bamlanivimab, which is the monoclonal antibody for COVID infections, perhaps we'll get more comfortable with monoclonal antibodies. But I think it's something that we need to look at better because of the studies that show how much effectiveness it can have.
Thank you, Dr. Hermansen. So we have a question in the chat, and I think that, you know, in the interest of time, normally we keep the chat, the Q&A session after the lecture open a little bit longer, but I think the best course of action for today would be to answer Patrick's question. Please write down any questions that you have so you don't forget them, and then let's load these at the end after we have our case presentation, so we can make sure that we get through that case presentation, and we're making sure that everybody can get out of here more or less on time, because this, like I said, this is a big one, and there's a lot of information. So I'm just going to read out Patrick's question. Do patients change their biologic medication during the course of their illness? If so, how often do they do so, and according to which criteria?
Yeah, that's an excellent question, and one that's research worthy as well too. In terms of the changing their medication, I can actually refer you to that same study where I talked about the general under prescription of biologics as well. So if you look at that study, and Patrick, I would send you to Inselman et al. So Inselman, Inselmann. And when they went into the Optum's labs warehouse data, they saw 100, I think they had about 4,800 incident users, so no usage of biologics in the previous 6 months. And then they had 123 multi-biologic users, so 123. So there isn't that many people who class switch or drug switch, but it's definitely present. So with persistent symptoms after a period of 4 to 6 months on therapy, you might be able to class switch. Now you might ask, which class should I go to? Should I go with if I'm on an IgE, should I go to an anti-IL-4 13, or should I go to an anti-IL-5? And the truth is we don't have good data to say that one compared to another in terms of those head-to-head comparisons to really give you sound advice. But just based on experience, we can say that sometimes you do get a better response when you do target a different part of the pathway. There are some people who do describe very small studies of using more than one biologic at the same time, and it's really, really small. I don't, and I have not had any experience. I prefer to class switch, but these are really important points that really require more investigation. And better, more pragmatic comparative effectiveness studies more than anything else. And then you asked the second part, you know, what is the criteria? It's really based on control at 6 months. And I think this is the point that, you know, Herm and I we share this in terms of patient-reported outcomes. Like, it isn't just about exacerbations and steroid usage and albuterol usage. It's also what the patient or the caregiver reports. Like, if they're not having a great quality of life, if they're still having problems, these are very important discussions in terms of switching the biologics as well.
Thank you.
Thank you. Alrighty, so let's switch over to our patient case presentation. This will be presented by Dr. Jassal as well. We're really putting you to work today. So, Mandeep, take it away.
So this is an 11-year-old African-American female born at 34 weeks gestation. She did have NICU requirements at birth, and she did have non-invasive oxygen requirements for about a week or so, so nasal cannula. She did have some symptoms that were concerning for respiratory issues in the first 2 years of life. She did have a history of RSV as an infant. When she does demonstrate asthma symptoms, it's usually a cough. And the cough is occasionally productive with yellow sputum. It does not occur with sleep. She has expiratory wheezing as well as shortness of breath. She does report that she responds well to albuterol, although Xopenex is preferred by the family because of their perception that it makes the child less excitable. They do think that she responds well to steroids, usually within the first 3 to 4 hours. The chief triggers, they say, are upper respiratory tract infections, so viruses, and exercise, largely outdoor-based exercise. She's on a pretty extensive asthma controller regimen, including high-dose Advair twice a day, Singulair once a day, Spiriva Respimat, 2 puffs once a day, and then albuterol, 2 puffs every 4 hours as needed. She is also, in the past, she'd been on high-dose QVAR as well as high-dose Flovent. There is a high level of concern for her medication adherence when we look at her refill history, although I'm writing good refill history. So we'll get to that and we'll return back to that to clarify. 2 hospitalizations over her lifetime, none required ICU care. There was no need for intubation. But BiPAP was required on both of those hospitalizations. She's had 4 ED visits in the past year, 5 steroid courses, so add 1 more steroid course in her primary care doctor's office on top of the ED. Her last asthma control test was very low at 9 3 months ago in her primary care doctor's office, and the respiratory review of systems was negative. There is a strong family history of asthma, and no other significant respiratory history in the family. She gets about 2 pneumonias a year, and they're often treated with joint antibiotics and asthma therapies. Almost always the 2 go together. So she gets antibiotics and steroids during these, and she usually responds to these joint regimens within the first 1 to 2 days. As far as she doesn't have any anaphylactic episodes, no past allergy testing. She did have EKGs during one of her previous hospitalization. That was normal. She had been trialed on an anti-reflux medication, didn't change her asthma control. She does have a history of rhinitis. She's on Allegra. No history of eczema and no baseline ventilatory requirements. She does have a history of sickle cell trait. And she does have a history of migraines, but is well controlled without medications. She is followed by neurology. She had been followed by neurology in the past, and she has a history of ADHD. She is also on Allegra, like I mentioned, Allegra earlier, and Binase as well too for the ADHD symptoms. She does not have any recent lab work. She is very, very scared of needles. And so it becomes a very challenging thing trying to get lab work on her. And so as far as the diagnostic studies are concerned, she does have on PFTs a severe obstructive ventilatory defect that was reversible with a bronchodilator. She did have a chest x-ray that showed a right middle lobe density that is consistent with atelectasis, but because of that pneumonia consideration, all too not people treat with both antibiotics and with an asthma-directed therapy. She did have a chest CT as a follow-up just to make sure there isn't any issues in that right middle lobe, and it did show signs that were more consistent with atelectasis. No cavitary lesions, no issues with bronchiectasis, so I don't think we're missing any other types of underlying lung disease. She does have great saturations on Rumer. She has 25th to 50th percentile for weight, 50th for her height. She's wheezing in the office, expiratory wheezing, and she's heard wheezing throughout all lung lobes. And to answer the questions, I do want to say the refill history was indeed good. Not bad, but good. So with those, the chief questions are what laboratory workup, if any, is indicated to characterize her asthma and potential treatment options, knowing that, you know, whatever stick you're going to get for your needle should end up being the one stick because of her difficulties getting blood work. And is there any possible change we could consider in her daily controller regimen? And does her fear of needles influence your possible future decision to start biologics if you're thinking about it? And the final part was about the chest imaging and this approach in the past to treat jointly with antibiotics and asthma-directed therapies. In other words, would you continue to do so, or would you alter your approach?
Alrighty, so now's a great time if you had any other questions, just general questions, of course, or if you'd like to address the case. And I can also, was it helpful to the group when I added the questions into the chat last week? Yeah, all right, let me pop those in there while you all work on your comments.
I guess my thoughts is that her current regimen isn't helping that much if she's being hospitalized and being on steroids or in the ER so frequently. I'd want to explore that needle phobia a little bit more and get an idea of where that originated and how we can get over that, because I feel like we do need some blood work to help determine her ability to be on potentially a biologic. You know, I know that needles are scary, but so is BiPAP in my mind. So, you know, maybe that's more as a parent speaking than the actual patient. But I wonder if they've ever tried Emla cream or Benadryl or, you know, some kind of, you know, treat afterwards, or exploring that a little bit more.
Yeah, that's a great question, Herm. I don't know what strategies were used in the past. Normally we were rushing to get labs with every severe asthmatic on their first visit. This time around was more counseling, saying it's going to be common, and we were planning on involving child life in those future discussions that kind of help. And usually they're the ones to help apply the EMLA as well too, to have basically a typical healthcare provider be helping in that process.
You know, in our asthma home visit program, one of the things that I think would be really helpful, and I'd love to get a look at the home of this child and see if there's anything else going on there. As we know, you can give someone as much medication as they want, as you possibly can, but they're not going to get better if there are any environmental things, if there was mold in the home, if there were pets and smokers and cockroaches or mice or anything like that. And so, and you know, also even approaching the cleanliness, how often are they washing the sheets, and changing the furnace filter, and what is the MERV rating on the furnace filter, and you know, so much that goes into the environment, and fresh air exchanges in the home as well. So yeah, there's so much to do. Oh, bless you for trying to plow through what's perfect for each family, because it's so variable and it's a lot of work.
Andrea, you brought up a really good point. The NIH, like we mentioned in an earlier talk, has now, as of December, is recommending only multi-component environmental interventions, so not singular. So it's got to be a complex intervention. So depending on the family, it might be very challenging, or depending on their home environment, if it even can be modified.
Yes, and it's also difficult because you don't want them to think that you're judging you, or that I'm judging them, or I'm saying that they're not keeping their house clean and they're not doing things to protect their child. I mean, we understand everyone is busy and everyone's working, and so, you know, how can we help you? You know, we're here to help. So when I come into a home, that's what I talked about. I'm here to help. Let's see what we can do. Let's pick one doable task that you could work on a week. You don't have to do all of this at once. So long term, these are all the ideas that we have, and having them set a goal, I know they're going to follow through on it if they're going to set that goal. So if their first thing is just starting to vacuum more often, vacuum the child's room more often, washing the sheets more often, if they can call on the landlord to come and check the furnace filter. So kind of breaking it down into biteable little chunks, little bite-sized pieces for them to get started on is really helpful, and letting them know that we're here to support them. We're not judging. We're not going to do the white glove test. We're just here to help them and see if it would make a difference in the asthma control.
Yeah, and while you're looking at goals, I noticed that one of the things mentioned in the case was limiting outdoor activities. And I want to know kind of what this kid's quality of life is. What do they want to do? Are all their friends on the basketball or soccer team and they're not able to do that? And especially with the isolation that we're seeing with COVID, you don't want that to be yet another factor that, harms their health, both physically and mentally.
So we have a question from Patrick in the chat. Could pheno measurement be helpful to characterize her asthma?
Yeah, Patrick, that's a really good question. So for those who don't know, pheno stands for fractional exhaled nitric oxide. And when we think of nitric oxide and it's where it is derived from, we think it's related to eosinophilic based processes in the lung. So when we think of classifying eosinophilic asthma, pheno could be potentially helpful. Now, the more updated forms of thinking are saying, don't rush and get it, but if you're kind of in a quandary, you're in a diagnostic quandary or a management quandary, that's where pheno could be helpful. But to do pheno, that's part of the thought that you also need to pay attention to, because to do pheno, you have to have a regular exhaled breath, and you gotta keep it pretty level for a period of about 10 seconds. So you're breathing out all the way out to 10 seconds. And a lot of kids can do it. She obviously had a decent amount of decent lung function testing ability, but not all kids can do it. So that's one very important part of getting a pheno value. Also, there could be multiple confounders with pheno too that can alter our results, but it could be potentially helpful. For us, we don't too often get pheno values outside of another disease process called primary ciliary dyskinesia. But in general, it could be helpful, but I think we can use other tools that are easier to acquire. But I hear where you're coming from, that it could be an alternative instead of getting an injection, and getting a needle and getting blood work. But if we were going to get a biologic approved, we need numbers that are a little bit more reliable in terms of eosinophils.
Yeah, I was going to say that too, Mandeep, that I would be surprised you can get an approval without those labs.
Oh.
So it's helpful maybe to get the pheno, but it's probably still not going to get approved until you have the numbers.
Do we have any other questions from the group? Feel free to unmute yourselves and jump in or ask in the chat. Alrighty, so Mandeep, would you like to summarize for us?
Sure. So can you remind me her age 1 second, Ashley? Was she 11 or 14?
Oh, her age? I'm pretty sure she was 11. Let me just double check.
Thank you.
Yep, she's 11.
Perfect. So she's an 11-year-old with severe asthma on a high-dose controller medication, including at least 3 controller medications, so an ICS agent, a LABA agent, and a LAMA, and I think she's also, I don't know if she was on Singular, so she might have even been on 4 controller medications, but nevertheless, poorly controlled. Classical asthma triggers, responded well to asthma-directed therapies in terms of prednisone and albuterol. Seemed like she was taking her meds pretty well. And what other things we could consider would be the biologics at that point. However, there were a couple interesting things going on because it was the time of COVID. It was rising in terms of concern. So the family, the mother in particular, did not feel as enthusiastic about starting a new regimen and possibly coming in to our hospital on a regular basis to get biologics. And she had been because of those concerns, she preferred just staying with an inhaler or based on a simple standard of care inhaler therapy and non-biologic based route. So what we ended up doing is we put her on the smart form of therapy that we talked about earlier, where we use Symbicort as both a controller and a rescue agent. So we put her on this form of therapy as this pandemic was rolling through. We continued the rest of her regimen. Her asthma, like so many people before her, has gotten better during this pandemic, and she remains out of school. So in general, we did not need to start biologics. So this makes me feel, better about the thought that we got her asthma under better control because of multiple issues. I'm sure the controller therapy had about this much, but keeping out of school and not engaging in these forms of outdoor activities, which we know are a major trigger for her, are probably the bigger things. So changing her lifestyle, which is not a realistic strategy, I would hope, for this coming fall winter season. But it is something that we had to address and had to be cognizant of, and to be respectful to the mother's wishes, and being thoughtful about trying to keep her asthma under reasonably good control. And I did mention about the fear of needles and playing a part. I would say that in the future, if we were going to consider the biologics, I mentioned child life. I think we have an amazing child life department, and I think a lot of us, if we have access to it, should use them more often. They can help in so many respects. Needles are just one component, and they are very good at transitioning patients to getting used to needles, including our diabetics. So I really like that approach. But one thing I found is that once kids get used to these needles, not only do they feel comfortable, but they actually prefer to give it to themselves, because caregivers have a way of showing constant fear and always being scared hurting their kids, when the kids are always really pretty cool and chill. So they can do it a lot more easier and a lot more better than doing it as opposed to the parents. And then the final part was about the chest imaging findings. Often in what I see for patients who are treated jointly with antibiotics and asthma therapies, especially in pediatrics, especially if they respond really quickly to a regimen of antibiotics and asthma, it's usually an asthma-based exacerbation, and that's our key focus. Should have been treating the asthma first. And if they didn't respond well or in its entirety, we could talk about the addition of an antibiotic. But in general, the chest imaging findings of the densities are usually atelectasis, not pneumonias, and they respond well to an asthma-directed regimen. So that would probably be one of the bigger things that we try to change about her future course, and not using too many antibiotics at such a young age.
Thank you.
Mandeep, I think that's really helpful to talk about really normalizing needles, because this is something people are going to have for the rest of their life. And I know when my kids are adults now, but when they were younger, they had allergy shots, each of the kids, for 5 years. And then the middle son went on to do Xolair injections for about 7 years. And for us, it was normal. This is what we do. It's Tuesday, we're going for allergy shots. It's Friday, we're doing shots. And so for us, it is just, if you just normalize it, this is in our routine, this is what we do, bring a book to read, then we'll go get ice cream, whatever. But yeah, it's pretty interesting. I'm working in our COVID clinic, and it's interesting to see some of these big, strong, burly guys, and they're about to pass out because there's a tiny little needle. So, I mean, if we can start kids earlier in life going, this is what we do, and you're fine, and you can do it yourself. So yeah, great idea.
And now our knowledge questions. Question 1. Which of the following drugs is an IL-4 receptor alpha antagonist? Benralizumab, Mepolizumab, Umalizimab, Depilomab, or Reslizumab? And question 2. Which of the following is not targeted by the currently approved biologic agents? IL-5, IL-17, IgE, or IL-4? All right, thank you everyone for answering those. I'm going to share our responses. Okay, Mandeep, how'd they do?
Very good. Which of the following drugs is an IL-4 receptor alpha antagonist? The correct answer is Depilomab or Depexin. By binding to that receptor, you decrease, or you're blocking IL-4 as well as IL-13, so double the benefit. And which of the following is not targeted by the currently approved biologic agents? And the correct answer is IL-17. It is implicated in non-type 2 asthma. So the rest are all type 2 eosinophilic asthma related.
Excellent. Thank you. Well done, everybody. So as always, just want to ask if anyone would like to chat about one of their patients next week. We're going to be discussing shared decision making, and we will have our licensed clinical social worker, Aaron Sutton, on to discuss his approaches. All right. Well, I want to say thank you all so much for joining us today. I know this is a lot of information. Take some time with it. Please let us know if you have any questions. Feel free to reach out during the course of the week, and we'll make sure we get those to our hub team. Otherwise, we hope you have a wonderful week. We'll see you next Tuesday to talk about shared decision making. All right, Echo clap. Thanks, everyone. Have a great day.